Hi everyone, this is Dr. Baker Townsend, and Dr. Coma and I would like for you to get familiar with some newborn principles and assessment, and this is our newborn simulation. So you will be checked off on taking a temperature, completing bulb suction, doing a heart rate on a neonate, taking respirations on a neonate, bathing a neonate, wrapping a neonate, doing a Ballard or Dubowitz exam, and we just need you to know the basic principles, and then being able to note any red flags on physical exam. We'll put your names here and then we'll check you off. So moving down, so I would like for you to watch the APGAR score in the ATI web links that you have, and we do APGAR scores. Dr. APGAR created the APGAR scoring system to really tell what babies needed help at delivery due to deoxygenation. So the total score that a baby can get is 10. And there are 5 parameters which we use, and it's heart rate. Over 100 is great. Respiratory effort, if they're crying, and they have good crying, that's awesome. Muscle tone, we want them to have active motion. We want them to be well flexed. That would be in the flexion position and not extension. Reflex irritability, this is when we rub them. They should cough, sneeze, or cry. And then their color, we would like for them to be completely pink. When we look at our skills from ATI, we can see right here, I'm sorry, let me move this over a little bit for you, that they have the APGAR scoring link right here. And all you have to do is press it, and it will give you complete information about the APGAR score in 3 minutes or less. Okay. So we want you definitely to look at these links. Next, there is a assessment tool for estimating how old the baby is at delivery, meaning how long was the baby in utero? What is the gestational age of the baby? So you will go to the ATI link, and I'm going to show you that one again. I hope it doesn't make you sick, because it made me a little bit sick looking at this stuff. I'm going to move it into focus. And you can see on the ATI module, there is a gestational age assessment, and you will press it here, and it will go through all of the parameters of gestational age testing and show you how to do that. Okay, so here's the scoring sheet for the gestational age assessment. So what I really need to show you is that when you are looking at these parameters, the first, or this top one, is based on neurologic maturity, and this bottom one is based on physical maturity. And we can see that -1 and 0 are very immature neonates, and that 4s and 5s are mature neonates, and some can be post-days, which is greater than 40 weeks gestation. So once we look at all of our physical exam parameters, and then we check the box that matches the numeric value given to that parameter, we will add them all up. So let's say we got 20 on the top portion, or let's say, 20 on the top portion, and we got 20 on the bottom portion. So, that would be a total of 40. And you can see over here the score says 40, and that would mean that the baby was approximately 40 weeks gestational age. Now, there is a caveat that tells us that it could be the baby could be plus or minus 2 weeks. So if we got a score of 40, this baby could be anywhere from 38 to 42 weeks gestation, based solely on our physical exam. When patients come in that have not had ultrasounds or no prenatal care, we must use this tool to accurately assess how old the neonate actually is by gestational age. Now, we will use that to determine if they are very small, average, or large for their gestational age. So we could see that, say for instance, we got 40 weeks. We would put a line here, a vertical line, which would be our gestational age that we got from the actual gestational age exam. And then we would take a horizontal line plotting their weight. So let's say that the baby was 3,000 grams. So we could see that a baby that was 40 weeks and 3,000 grams would be within the yellow line, which is average for gestational age. If the baby is out here in the green, the baby is large for gestational age, and down here in the pink would be small for gestational age. And both of these would have nursing interventions which would accompany that. So you can see that on your gestational age assessment exam. Next, we want you to review the video and know how to wrap a baby. You'll be checked off on that. And let's just see, it's a quick video of us wrapping a baby. And you can see that we will show you in a minute how to wrap a baby. Let me move this over. Okay. I hope I'm not making you guys nauseous. Okay, next would be taking the heart rate, respirations, and temperature and measurement. That is on the ATI assessment links and videos. And then people many times have a difficult time with respirations. So here's another little tiny one that you can watch if you like. I want to explain that you are responsible for knowing these normals for heart rate, respiration, and temperature. Heart rate, 110 to 120 is a gray zone. If the baby has always been in that area, that's okay. But if the baby was previously 120 to 160 and dipped down to 110, that would be an abnormality. Respirations, normal is 40 to 60. If the baby is asleep and is in a very deep sound sleep, the respirations may go down to 30. So that's the only time that would be normal. Temperature, axillary temperature, so if the baby is not ill, so if this is a newborn nursery and the baby is not ill, we take an axillary temperature. And the normal axillary temperature is 97.7 to 99.5 degrees Fahrenheit. And we make sure that we hold the thermometer vertically under the baby's arm so that we can get good contact with the tip. And so you will be able to see in the video that it is vertical across the body and not horizontal. That's very important in your measurement of the temperature. We want you to know how to use the bulb suction. Again, this is a 1-minute video and you can click on that. Bathing a neonate, which we just never want to contaminate our water. That's what I really need to say, because baths need to be very quick because babies lose heat very fast and they lose a lot of heat via evaporation during the bath. So the quicker the bath, the better. So the less contaminated the water, the quicker the bath, so we don't contaminate our water. Next, we want you to look at the red flags for neonatal assessment. So when you go to the nursery or to the NICU, we want you to evaluate newborns. Of course, in the NICU, you never touch the baby without asking. You never even touch the crib or the incubator without asking. But you definitely, when the time is correct and the nurse is giving you the go-ahead, you can look at the baby and look for some of these signs. Now, when you're in the newborn nursery, same thing. You always wash your hands prior to touching a baby, and then you always want to make sure that you have permission from the nurse. So the first thing is you're just going to look at, are they awake or sleeping? Are they in flexion or extension? Babies are well flexed when they're born. meaning that they have their arms bent and their knees bent. When you have a baby who's floppy like this and with no flexion and you have just full extension, it gives us cause for worry that there could be a neurologic injury. We want a nice lusty, which is low, and vigorous, loud cry. A weak or no cry makes us very concerned. Skin lesions, you would tell us the lesions and describe them. The color, we really want the color to be pink, but your red flags are here. If the baby is yellow tinged, like this baby, that gives us pause for concern that there could be some jaundice. Of course, we want our baby to be warm and not cool. We want our mucous membranes to be moist and the baby to be hydrated and not dry. Our skin texture. So, newborn babies that are premature can have clear skin, and you can see all these vessels on this skin. Now this is some Eshar material from this baby had a surgery, but I just really want you to look at this area, and you can see how premature this baby's skin is because you can see the veins directly through it. And then translucent, it's a little thicker than clear, but definitely not thick. Thick is good. Peeling is okay because that means that they're term, but cracked and leathered, and you can see how this baby is cracked and leathered and it's peeling really badly. This would tell you that this was a very post-States baby. Lanugo is a normal gestational change during gestational development, and it's this fine hair that covers their shoulders, their back, and their abdomen. It holds the vernix on. The vernix is the white, it looks like cottage cheese, but it's actually oils and skin cells, and that protects the baby. But around 36 weeks, all this lanugo, 34 to 36 weeks, this lanugo starts to fall off. So if a baby comes out and it has a lot of lanugo, we really worry because we know the baby could be very immature. Mostly bald or entirely bald tells us this baby is an older gestational age. Vernix, the amount, is it scant, moderate, or is it copious? That's a normal. Milia are just little collagen collections on their nose, cheeks, and chin. It just looks like a little whitehead, but it's actually collagen, and we encourage patients to leave that alone. Mongolian spots are just discolorations that are darkened on the skin of any baby, and usually it's near the sacrum, and it's dark, and so people tend to worry about it, but it is completely normal because that is just where darker skin people have a greater concentration of melanocytes. Erythema toxicum, so erythema means red, toxicum with a white center is newborn rash, and this is a normal thing. It looks like, I hate to say it, but it looks like cystic acne on babies, and it is a very normal thing and nothing to be super concerned about. Telangiectatic nevi is a stork bite. This is where you'll see dilated veins on the back of the baby's neck, sometimes on their eyelids. Their nails should be to the end of their fingertips. That tells you that the baby is term. Their hair, they can be bald or thin, but we want it to be evenly distributed, thick. We don't want a variant, like we don't want a spot where there is no hair and all the rest of the head has hair, or there is a spot where there is very thick hair and the rest of the hair is very thin. Head should be rounded. Kappa is just a little bit of edema on the head because remember this baby was head down in the pelvis and probably went through about 120 to 160 contractions, and so that caused a little bit of dependent edema on the head, and that is completely normal. What is not normal, however, and is a red flag, is a cephalohematoma, obviously head bruising, blood collection. And so you can see this can be from an injury during delivery, and so you would see that this, what's interesting is with caput, it crosses the suture lines. You can see how it goes across, but with a cephalohematoma, it does not cross the suture line, and it is actually a bleeding site. Blood is trapped. So this is very worrisome. As we know that the head has very mobile plates, we know that when the bleeding continues out this way, it can also push on the plate and create some ICP. So this causes us pause for concern. There's also trapped red blood cells in here. The body will process those red blood cells, break it down into heme and globin, and as we know, that can elevate the bilirubin level. So we're very concerned about that. So we want a bilirubin level if they have a cephalohematoma. The fontanelles should be, the anterior should be a diamond shape, and we can always remember girls wear diamonds in the front, and you just draw a little diamond here, and they should be flat. If we have a baby that has a bulging fontanelle, if it's only when they're crying, that is normal. But if it's bulging like this, and it's bulging here when it is not, when the baby is not crying, that is very abnormal. That tells us that we can have some degree of ICP. Depressed is here. You can see depressed, and you can see this little depression where the anterior fontanelle is. That can tell us that there's some dehydration. This really actually looks sunken, which is not good. Posterior is a triangle shape. And again, same things go for the posterior. And then the sutures should be open. You can see how all of these sutures are open. Okay, and that's good. That allows the baby's head to grow. It allows the plates to shift, and that can cause the sutures to be overriding. So this plate can go over top of that plate, totally normal, causes a cone head. It usually resolves on its own, no big deal. And so if we find that the sutures are either open like this one or overriding where one plate is on top of the other due to positioning of the head and compression of the head in the pelvis, and that would mean it was overriding or molding, that's totally normal. But if it's fused, and you can see this posterior central sagittal suture, you can see this central sagittal suture is absent. It is fused on this neonatal head. This baby's head cannot grow. And so this is a very distinct red flag that tells us that this baby needs to be evaluated immediately. This baby will actually go to surgery and have surgery on these to open them. Baby can have scratches on their head or trauma. We need to always look at that. The neck should be supple and easily mobile. Epicanthal folds, which are little tiny pieces of skin that cover the lacrimal duct right here, very common in Asians. They can be present, and that can be a normal thing. Discharge, as long as it's not a lot, it can be normal. But if it's a lot like this could indicate gonorrhea or chlamydia presence and infection in the eye, which can cause blindness. So whenever we see this heavy discharge, it causes us major concern. The sclera should be white. Of course, if it's yellow, we're concerned about jaundice. And then a subconjunctival hemorrhage can be here. It can be normal, abnormal, depending on what is accompanying it. So if you have other injuries accompanying it, they could be very bad. But if you just have it from them having a quick delivery, it could just be high pressure on the head and eye, which created it, and then that will go away. We do give eye prophylaxis to every single baby that comes out, erythromycin. We have a few others that we give, but this is the most predominant one to prevent blindness from gonorrhea or chlamydia, and we give it to everyone. Ears should be in line with the external canthus. So here's the outer canthus. The ears should be way up here, and you can see this baby has low set ears, which is can tell us there could be phases or some type of congenital abnormality. The ears should have, when we take the ears and pull them back, they should readily recoil, as you saw on the Ballard score. The nares should be patent, and we look at them while the baby is sucking on your finger. Color and mucous membranes, they should be pink. They should not be yellow tinge. Epstein pearls are normal. They're just little collagen collections under the gums, and the palate should be intact. Cleft, here is a normal baby, normal lips and palate. And then here is a unilateral lip cleft. And then here's a bilateral lip cleft. And then here's the palate and then the lip. So here is a unilateral palate and lip, and then here is a bilateral palate and lip. The lips should be symmetric. When you look at them, one side should not be drooping. They should be symmetric right to left, left to right, upper to lower. So now on chest and lungs, the respiratory rate, as you saw with taking vital signs on the ATI videos, we talked about this, 40 to 60. They can go down to 30 while sleeping. The rhythm should be regular. The breath sounds should be clear to auscultation bilaterally. O2 set should be 95 to 100. Adventitious sounds. So if we hear some wheezes or rhonchi, any type of fluid crackles in the lungs, that makes us concerned because we know these babies are going through a major transition, and so we have to find out why that's going on. Now, if they have respiratory distress, that is very concerning. That's when the baby grunts, retracts, and nasal flares. And here are two videos that are excellent to show grunting, retraction, and nasal flaring. This is a lot of work right here when they're going through this respiratory distress. So a lot of times they are burning calories very quickly, so they need to access their glucose. As you learned in Anatomy and Physiology 1 and 2, well, actually Physiology 2, babies are born with brown fat, and so that brown fat helps them to regulate their temperature and their glucose. When they're burning that brown fat very rapidly, or they don't have enough brown fat, as an example of a premature baby, it can cause them to get really cold, and it can cause their glucose to go down. So this is why we always put, if you're having a baby in respiratory distress, we definitely want you to evaluate their temperature and axillary temperature and potentially do a glucose on your baby. Breast should be everted, as you saw on the ATI video. The tissue should be 3 to 10 millimeters, and there may be some witch's milk. I hate that terminology, but that's what they call it, and it can be from the parents just manipulating the nipple as the estrogen. The baby was subjected to very high levels of estrogen at delivery, and so when the baby comes out, that estrogen falls, and if there is nipple stimulation by the family, accidentally or however, it can cause the prolactin level to go up, and the baby can have some witch's milk. So it can be normal, but we just tell people don't mess with it if you see it. Cardiovascular system, we're going to listen to the heart rate. It should be 120 to 160. Again, if it's 110 and it's always been 110, that's okay. We want to listen to make sure it's regular, if there's any murmurs. And of course, we're going to go in the aortic, pulmonic, herbs, tricuspid, and mitral, and we're going to listen with the bell and the diaphragm. We'll talk about one of the ducts closing, and that's the ductus arteriosus. So if you're in the pulmonary region and you hear a murmur, it could be the ductus arteriosus closing, and we'll talk about that. You want to check their pulses, femoral 1 to 2, good, brachial 1 to 2, and they should all be equal. Abdomen should be rounded. There should be a 3-vessel cord. So when you look at the umbilical cord, you always count them. 3 is normal, 2 is abnormal. There's 2 arteries and 1 gigantic vein. The vein is how they get oxygen in from mom to them. And the 2 arteries is how they get rid of CO2 and waste. And that pushes it back from them to mom. When we have a 2-vessel cord, that is of great concern, because we know we have, and you can see it right here where this 2 goes into 1. When we have a 2-vessel cord, it can increase the CO2 in the baby, which can cause some acidosis. And so while we know that the baby's getting plenty of oxygen through the through the vein, we worry about the CO2 elevating with a baby with a 2-vessel cord. So you always want to check that. You want to listen to bowel sounds, make sure that they're present bilaterally and there's no masses. Musculoskeletal, of course, we always talk about we want a well-flexed baby. We don't want a limp baby, and we want that movement to be symmetric. The gluteal folds, which are the buttock folds, should be equal. If they're unequal, that can cause pause for concern. It can tell us that we could have a congenital hip dysplasia. Ortolani's maneuver is where we take the hips and we make them go round and round, and we make sure that they're seated and the trochanter is seated safely in the pelvis and that they are not popping out. The clavicle should be intact. You should not feel a bump on a clavicle. The spine should be straight and closed. So here is a baby with a dimple, a spinal dimple, which could mean nothing. We just pull it apart and make sure that we can see the bottom of it, that it is absolutely closed. Because if it's not closed, that could be a communication with the spinal system, and it runs a big risk for infection. So babies like this that have a dimple, that if we can't see it's closed, they go for ultrasound. Here's one that has a dimple that is open, and that would be considered spina bifida. And I actually put a spina bifida little diagram on here. A spina bifida occulta is when they're missing a spinal vertebra and there's a little tuft of hair. And usually this doesn't cause a lot of problems. It can cause some, but not very much. A meningocele is where you have some fluid collection and a bulge. But what's very upsetting is a myelomeningocele, and you can see it here, is where we have bulging of the nerves and, coming out of the back, which obviously can cause neurologic damage. This is a baby's spine that has congenital scoliosis, and we don't want that. We want to make sure that our baby's back is straight. Genitalia, we want the testes to be down. We want them to have 2. We want the meatus to be centered. Females, a vaginal tag can be normal. It's just a little piece of skin tissue. And we tell moms not to mess with it, moms and dads. The majoris should be large and the minoris should be small. And you saw this on your gestational age assessment. The anus should be patent and meconium stools should be there. The reflexes are here. And you can access your ATI videos and look at these. And then, of course, we'd always want to know ins and outs. So how much did they eat? What did they eat? What was their feeding behavior? Their stools, how were their stools? Number of voids. The rule of thumb is 1, 1, 2, 2, 3, 3, 4, 4. So on the very first day, they should have 1 void and 1 stool. Day 2, 2 voids and 2 stools. Because every single day, breast milk increases, their stomach stretches, and so they have more intake and they have more output, as long as they're getting enough nutrition. So counting the stools is very, very important to make sure that the baby is getting the voids and the stools, to make sure that the baby is getting enough breast milk. So 1, 1, 2, 2, 3, 3, 4, 4. If it's less than that, then we start to have concern. Stool patterns. And then these are some baby lab stuff, and we'll do that more so in clinical, and we'll be teaching about this the whole semester. Don't worry about this for your checkoff, though. Okay, if you have any questions, please watch all these videos, and then come to SimLab. I'll have a sign-up sheet for you, and we're very excited to have you this semester. Thank you.